Welcome, everybody. I am so excited here. Today, we have a sleep expert, Dr. Brett Neilson, and Brett and I have gone back a little bit of time, but for those of you who don't know, my name is Matthew Vra, physical therapist with OPTP Next Level Interviews. Today, we have Dr. Brett Neilson. So, Brett, can you talk to us a little bit? Well, first of all, let's have you introduce yourself. Let's introduce yourself and tell a little bit about how long you've been in the industry and a little bit of your background.
Yeah, absolutely, Matthew. Thanks for having me today. Gosh, I've been in the industry now for over 15 years, I believe. I graduated from University of Puget Sound out in the Tacoma, Washington area back in 2009, and I currently reside in the greater Seattle area. Let's see, you and I go back to really Bellin Health days and completing our DSC together at Bellin Health. And I think we graduated when, in 2021,
I think that's
maybe.
about that. Yeah.
I think we have that right. But yeah, so my current kind of full-time gig, if you will, is I am part of the core faculty team at Hawaii Pacific University in Honolulu, and have been with them for almost 5 years now. I still see patients, and I've been seeing patients the last 5 years with Luna physical therapy, and which is, if you're not familiar with Luna, right, is outpatient physical therapy, but delivered in home. So your typical outpatient client that you would see, I'm just coming to them instead of them coming to me. But that really kind of ties nicely into our topic today of sleep, because I get to see my patient's environment, right? And my client's environment, where they sleep, and how they sleep. And so it really does give me somewhat of an advantage in this, space that we're going to be talking about today. So that's just a little bit about me, but I'm sure we'll unpack a little bit more as we go forward here.
Yeah. Huh. That's interesting. Very cool. So what inspired you to specialize or really focus in on sleep, and how has it approached or, changed your approach with patient care?
Yeah, so gosh, I mean, in the early parts of my career, I started recognizing, some patients and clients would do really well at physical therapy, right? You do all the evidence-based approach and they, do amazing. And then you have other clients that you expect to do amazing with the exact same approach because it's the exact same diagnosis, but you recognize like, wow, this is not working for them. And so that was like my entry into pain sciences. And then, of course, meeting people like Dr. Adrian Lowe, and learning from him, really opened up my mind that when we're treating a body part, right, it's really connected to this thinking, feeling, emotional human being, which makes it so much more complex. Well, fast forward and kind of diving into pain sciences and kind of recognizing like maybe there's this missing link. Like, what is it? What's the thing that gets somebody to move forward with their recovery versus holding them back? And that really centered on wellness. And then I think the real true big aha is having kids. When you start to experience sleep deprivation yourself, and you start recognizing how you are not yourself, you are not your best version of yourself. When you aren't sleeping well, you have a short fuse, all of those things, you really kind of like opens up your mind to like, wow, I wonder how many of my patients or clients aren't sleeping well. And I can imagine that if they're not sleeping well, A, it's going to be tough to recover. B, they probably are experiencing more pain. And so am I just trying to, kind of push something uphill? Right. And if we could level that off with, taking a step back and looking at wellness aspects like sleep, could that be that missing link that kind of helps propel that person forward? So, yeah, I mean, unfortunately, having kids is gonna give you that experience of sleep deprivation, and I think it's helpful sometimes when you get to experience it from the side of the patient or the client, right? So.
Yeah. Because I'm going to guess, I mean, I think back to my, master's of physical therapy and then transitional doctorate. We didn't really even talk about sleep. So
No.
where did you kind of find out about this missing link for your patients? How did you kind of stumble upon that?
Yeah, so the DSC program at Bellin College is amazing for anybody who's looking to, go into, get your terminal or academic doctorate degree. I can't say enough great things. And really part of that is you've got to produce a published, research study, and you've also got to produce a published review, so a systematic review or scoping review. And we do these as parts of teams, right? And so early on in that program, you have to identify, what do you want to focus on, and what, research direction are you going to head in? And so, thankfully, one of the um, instructors or professors there was Dan Rohn at the time, who also has an interest in sleep. Me and my partners, Chris Dickerson and Mark Shepard, were also got really interested in sleep. We connected with Katie Siensikong. If you don't know Katie, she is like the sleep expert in physical therapy. And we're able to connect with her and, have her mentor us a bit, share resources and collaborate. And so that's, probably the biggest influence there is connecting with recognizing this interest and recognizing this missing link, and then connecting with people who are already in that space. And there aren't many who are in the, sleep space within the physical therapy realm. So that's probably the catalyst to moving forward.
Got it. Yeah, I mean, I remember, having you do your presentation for a lot of us. So very cool stuff. Now, I think you got the stuff published. I don't remember where was that?
Yeah, clinical sleep medicine is where we have those published, and I don't know if there's a possibility of linking to this presentation, but if there is, we happy to provide the links for those two studies. So one was a more or less cross-sectional study looking at really the incidence of sleep, but also kind of the dysfunctional beliefs and attitudes around sleep in patients seeking spine care or seeking physical therapy for spine care. So that was a really interesting study that we can kind of dive into a little bit. And then we also looked at a scoping review, because there's published guidelines, and there's actually 4 or so published guidelines for researchers on what type of data they should be collecting in clinical trials. And one of those happens to be measures of sleep. So we basically looked back all the way to like 2010, which is when the first guideline was published, and looked at all the randomized controlled trials published, not just in physical therapy, but all, right? Medicine, etc., pharmacological studies, and how many of those were collecting measures of sleep. And it's less than 10%. There was another group, a couple years later that then looked at knee osteoarthritis, and it was the exact same thing. So the big take home of that study is like, if we're not collecting it from a research standpoint, A, how is that impacting the outcomes that the researchers are getting? But B, aren't we missing a huge opportunity to study and learn more about, sleep health and how that's impacting, patients' clients?
Yeah. Just so you know, I just typed your name in and sleep into that wonderful interweb thing called Google, and I think your measurement of sleep disturbance are not routinely captured in trials for chronic low back pain. A systematic scoping review of 282 trials was number 1. And then I think the other one, the restless sleep, is associated with increased anxiety in physical therapy students. That was number 2 on the list there.
Yep, so that's a little more recent one.
That's a little more recent, but again, just let the people know, if they want to, they won't have to look too hard when it's the top 2 posts there on Google. So sorry to distract myself from that, but I'm like, well, let's just see if I can. I remember there was, just your name and Brett Neilson, sleep, boom, those are the first ones that popped up. So awesome there. Can you talk to us about how you really incorporate these rehab tools around sleep, with your patients? What does that look like? How do you really work this into it? And maybe some of it's because of, how you are working with your patients with Luna, you said, but what is incorporating sleep stuff what does that look like?
Yeah, so I think the first step, and if you asked me, Matthew, like, what's one thing you wish all physical therapists did, it would be screening for sleep disturbance, right? And it's so simple. So that's really kind of the starting place. So let's kind of talk about this in the sense of, ask yourself, if you're listening right now, ask yourself, how many of the clients that I see on a daily basis are coming to me with sleep disturbance. And sleep disturbance means they have disturbed sleep, right? Their sleep is broken up. It's not great quality. It may be fewer than the recommended 7 to 9 hours. And so if you ask yourself that, from our research, we had 200 patients that were spread out clinics across the country. So we are thankful to have some of the Bell and Health fellowship students help us collect data. So 200 patients across the country seeking care for spine pain. So it's their very first visit. Out of those 200 patients, 61% reported that their spine pain adversely impacted their sleep. 3/4 of them reported getting fewer than the recommended 7 to 9 hours per sleep of 7 to 9 hours of sleep per night on average. And about a third of them were getting less than 6 hours of sleep per night. And I don't know about you, if I get less than 6 hours, I am not doing super well. So I think that's the first recognition, is that probably for every 2 people that walk through your door, one of them is not sleeping well. So we need to kind of start having these conversations with our patients. The simple thing is, and what I really recommend is like putting this as part of your intake form, right? That makes it really easy, because then it's there. You won't forget it. The client's going to absolutely answer it for you, etc. But really, there's kind of 3 or 4 recommended screening questions for determining whether you need to investigate further for somebody. So number 1, ask them how many hours of sleep they're getting a night. If they're falling below that 7 hours, there are not many people who function well below that recommended sleep window. So that's kind of first step, is identifying how many hours of sleep are they getting on average. Do they typically feel well rested after a night of sleep, right? So when you wake up, you feel charged and ready for the day most days, or are you feeling like, wow, I'm drained, I'm not getting enough? So, and then the third one is, can you rate your quality of sleep? Like, what's your subjective rating of it? And we just ask them, like really from really bad to very good. Like, where do you put yourself? Like, how, basically that's a satisfaction question. How satisfied are you with your sleep? And then I think the fourth important one, which really starts to help you make some decisions here, is asking them about how they think their acute condition, so whether that's spine pain or knee pain or shoulder pain, is impacting their sleep. What you're really trying to do here is like, is this a new problem that's related to the thing you're coming to see me for? Or is this something that's been going on for a while that's now exacerbated by what you're dealing with? Because if it's the acute condition that's really like, hey, I was sleeping well 2 weeks ago, but I've had back pain for 2 weeks and I can't sleep, quality's down, my hours are down, all of that. Okay, great. In that case, we really just want to monitor sleep, right? That becomes one of your subjective asterisks that you're asking your client about when they follow up. How's your sleep going? But really, you're just monitoring it, and then you're treating the back pain, because that's likely the thing that's impacting their sleep. We don't need to do anything fancy. We don't need to teach them sleep hygiene or sleep health. We really just need to focus on the things that we do best, which is physical therapy, and then monitoring their sleep condition to see if maybe down the road we need to do a little intervention there. So I know it's a lot of, kind of information, but that's really kind of like step 1 is that screening process. And so for me, that's what, where I start, right? That's how I incorporate it. And based off of that, then we can make some more decisions of, do we need to administer some formalized self-reported sleep measures. So like the insomnia severity index for somebody who's having difficulty with falling asleep or maintaining their sleep. We've got the stop bang, which is really the best measure for sleep apnea. And then your third, probably most common sleep disorder you're going to see is restless leg syndrome. Generally, there's a 1-question kind of screener for that one. Basically asking them about, uncontrolled your restless leg movements, essentially. But there is an actual, self-reported evaluation or self-reported questionnaire that you can administer for that one as well. But so that's kind of the screening. I don't know if you want me to keep going any further or redirect me if you.
No, but it really sounds like, you using that measure of sleep, how, how well they're sleeping as kind of a aspect, so you can set for goals or tracking. So you're kind of using like that PSFS, the patient specific functional scale, to use it as an indirect marker of how well they're doing. And they may care more about the sleep and they may even the back pain. So
Yep.
for you to tell me that, it was like, oh, yeah, that's just, it's an idea that I've thought about, but you just saying it in that way really helped solidify that, yes, I need to be tracking it to get at the lifestyle that this person is living in and
Yep.
how that condition, whether it be back pain, knee pain, or as you just said, or even shoulder pain, as you said, is affecting their life and their ability to function within their
Exactly.
world. So that is really something that's just really, I think that's going to really stick with me about,
Yeah.
when I'm treating patients and not just, again, it's always about the knee pain. How is this knee pain affecting your life? Or what can't you do because of your knee pain? We get so focused in on the knee, but,
Yeah.
maybe we need to take that step back and look at, sleep there.
Yeah. Because oh, go ahead.
Yeah, go ahead. No, go ahead.
I was going to say one of the barriers to incorporating sleep health, you mentioned at the beginning, is like most of us aren't trained in sleep health, right? We didn't get any education in PT school. It's not a CAPT requirement right now, but many programs are starting to incorporate it as, part of their, kind of health and fitness or wellness course or preventive medicine course. And so it's gaining in popularity, and our newer clinicians who are coming out are trained in it, or at least have a basic understanding. So I think what you're really kind of hinting at or talking about here is just boiling it down, making it simple, right? It doesn't have to be this big scary thing of, oh, I've never been trained in this. I don't know what to do with it. And so I'm going to ignore it. Right.
Yeah.
So
No,
yeah,
that's awesome.
yeah, and there's,
Go ahead.
oh, I was just gonna say, we can, kind of get into some of the treatment aspects as well. As we go forward, because I know we might talk about a case or something along those lines. But I do want to, also point out that there's really some great resources, and there's a whole published decision tree that Katie Sansakong and her team has put out there. It's available free through, it's called the Sleep Health Toolkit. It's available through Kansas University, where Katie is at. And you can just Google, Sleep Health Toolkit KU, and it's going to pop right up. There's a great resources for both providers and for patients. But one of those resources under providers is this cool one-page decision tree. So you can literally walk through, and that decision tree will help you make decisions as a clinician of oh, which measure should I give this person based off of how they responded to those screening questions? And if it's positive, what should I do? Should I refer this person out? What intervention should I consider employing, etc. So there's some really great resources. The APTA also has a well-published position statement that I was very fortunate to help draft back in 2020 that really outlines your role as a physical therapist. It's clear as can be. So if you're out there thinking is this within our scope of practice? It absolutely is within your scope of practice. Of course, you always got to look at your individual state laws, but most of the state laws mention nothing about sleep. And so the APTA then provides that guidance for those of us in states that are silent on physical therapist role in sleep health. So
yeah, a lot of times, I mean, a lot of these state laws also say we're fine when we talk about wellness, and this would be a part of that wellness. So
absolutely.
I just pulled up that the toolkit there, the Sleep Health Toolkit KU, and it's the top 2 results there. So I just went into the healthcare provider one, which was number 2 there, talking about strategies to enhance sleep screening tools and standardized sleep assessment, referrals to clients who need further assessment, facilitating change behaviors, additional resources. So this is something new to me. So that's awesome. Thank you very much for that.
Yeah.
But I do want to actually get into a case. Now,
yeah,
you brought up before about, people who are new parents, and I will tell you a case that I had, and that case is technically me, because one day, I think it was probably a week, about number 2 or 3 after the birth of our first child, and I had not been sleeping, and I started getting to work, and this is when I was teaching. I'm like, oh, I think I got an SI problem because everything just felt off. And that day I was doing practicals, which is good since I was, it was standing was really uncomfortable because I just everything just felt off. So great, I'll be sitting down. And about halfway through the practical with my DPT student, I looked down I have two different shoes on. Both of them are black, but they're very different. So that can tell you, like, oh, yep, here's my musculoskeletal problem. Like, oh, I think my L5 or I don't know, S. No, I just had two
Just
different shoes
shoes.
on because I was so sleep deprived. But could you really talk us through, probably not something humorous and as a quick fix as that for me, just like, man, you just wear better shoes and you'll be fine. But could you walk through a case example where you really found that improving some of these sleep strategies that you use and the tools that you helped really help, create this successful change or really change the trajectory of this patient's care?
Yeah.
Could you do that for us?
Yeah, absolutely. And the one that's like so fresh on my mind is somebody that I actually just we finished her episode of care or discharged her from her plan of care yesterday. And so 45-year-old female with some comorbidity, hypermobile. She's got diagnosis of lupus. She's on disability. She's had 20 plus abdominal surgeries. She's got, right. So there's a lot going on with this individual. So I actually started seeing her back in December of last year.
Okay.
I only saw her for 16 sessions though, between December and yesterday.
Yeah.
So, a really a nice standard care, but this is somebody who's dealing with chronic or persistent pain that we kind of see for a bit of time and we spread some things out, really keep that person tethered. And and ultimately she was ready for ending her care yesterday. So some other important factors: she lives in a house with several roommates, and her bedroom is her space. So when I first started seeing her, she was spending 10 to 15 hours a day in her bed. And that was like her place. So she watched TV in bed. She played on her phone in her bed. Of course, she tried to sleep in her bed. And so she's spending a ton of time in her bed. She's not really active. Even just moving between rooms, going upstairs. She lives in the basement, and so going downstairs was really challenging for her. So just to kind of like set the stage there, right? So when I first started seeing her, I screened her for sleep, and she's sleeping maybe 5 hours a night on average, but she's spending 10 hours in bed trying to sleep. So why that's important is we can look at kind of her sleep efficiency there, which would be less than 50%, right? So she's spending 10 hours in bed, but maybe getting 5 hours of sleep. So you can basically, the quick and easy math there is about 50% efficiency. So we gave her the insomnia severity index. She scored a 22 out of 28, which ranks as severe clinical insomnia. So at this point, you kind of have to make some decisions of like, what am I going to do with this individual? And how much is their pain condition impacting? So with this individual, I made the decision. She had some previous, seen sleep specialists in previous, nothing recent. And so I said, all right, let's just kind of proceed forward, right? And I'm just going to really monitor this. And let's see if we can't start to implement some strategies for her that can lead to better sleep, right? She's not dealing with sleep apnea, so I don't feel like I need to send her out at this moment in time. It's not urgent, right? So we'll keep monitoring it. Really, the thing for her is we can kind of break down sleep like interventions into really four buckets. And again, I have to give Katie Sansacong credit for this because again, she's been a huge mentor for me. But this, I think for me, helps make it really, really easy, is you really want to address things from four different, in kind of four different buckets, right? The first one is in training circadian rhythm. So how important it is for us to get natural light and get light early in the morning to feel awake and ready for the day. So getting this individual to be more active, getting them out of their basement bedroom that doesn't have a whole lot of light, getting out for a 5-minute walk, 5-minute morning daily walk, right? It doesn't have to be a big thing, but let's get a little sun exposure, some good light. Probably the biggest thing that led to the largest change for her is increasing her sleep drive. And really the big component here, it's called stimulus control. And stimulus control means that your brain associates your bed with sleep. And you can think of like a little kid, right? Little kids don't spend time in their bed unless they are sleeping. So what happens, right? It's 8 o'clock, they head to bed, we read a story, and boom, they're out like a light, right, in a matter of 5 minutes or less. And then they wake up, they get out of bed and go play. So as adults, though, we can develop not some, great habits of playing on our phone, watching TV in bed, doing all sorts of different activities. And so really the main intervention that we did for this individual was create this stimulus control and basically provided her some education of how we need to get her out of the bed and how it's important that we need to start reestablishing her bed as her sleeping place. And so, yes, the general guideline is that you want to use the bed for sleep or sex activities only. So the more we can get her out of the bed, the more we can establish this, this better connection with her brain. Some other aspects then is like the third one is reduce pre-sleep arousal. So really, before going to bed, we don't want to be on our phone, right? It's a lot of blue light coming right at us, very close, which is different than a television, right? Television usually across the room, not going to have as much of an impact. So reducing, time on phone just before, making sure we're not checking stressful emails or checking stressful news.
Doom scrolling.
Or scrolling through Instagram and feeling, bad about our life compared to, other people's, so trying to like reduce those like stressors right before bed, doing something that's relaxing, listening to music, reading a book. Maybe it is watching like a funny TV show. All of that's okay. And that kind of helps reduce that pre-sleep arousal. I always like to say, if you can kind of reestablish habits that you would that little kids do, right? Little kids like, all right, 7:30, it's upstairs, we're brushing teeth, getting our jammies on, right? We're reading books. Like it's the same routine every single day. And that really helps to reduce their arousal, which prepares them for sleep. And us adults, we need the exact same thing. And then the last is sleep hygiene. Sleep hygiene gets all of the credit and gets all of the, I don't know, the allure, if you will. But it's really, I think of it as like the fourth component. It's in importance. And sleep hygiene really relates to things like, controlling what we eat or drink, right? So we don't want to have coffee late in the day or high caffeine beverages late in the day. We don't want to have alcohol just before bed because that's going to keep your metabolism going, which is not going to help you sleep. Having the room be dark, having it be cool if we can, right? Making sure the bed's comfy. All of those things is really what sleep hygiene's about. So I think if you can approach those four things, though, that creates a really nice sleep program. But I can't emphasize enough that if a physical therapist, if you're out there what are the two take homes from what I'm, sharing today? Number one, screen. And then number two, talk to your clients about stimulus control and what they're doing in their bed when they aren't sleeping. Those two things can have a dramatic effect on somebody's overall health. So anyways, to wrap up this little case here. I discharged her yesterday. Her insomnia severity index score is now a 13 out of 28. Which puts her in the sub-threshold insomnia. So she's still having some problems, which is kind of to be expected, but that's a dramatic shift and a dramatic change. She's now sleeping between 7 to 10 hours per night on average, and her sleep's really mainly impacted when she has extra stress, right? So we now work on things like how do we control some of that stress that's impacting her sleep. So that's kind of the long and short of this case, and hopefully that is helpful for anyone out there listening.
No, I mean, you just provided some really good stuff that isn't just within, from the PT or the lifestyle medicine kind of approach with this. I mean, we go back to hey, condition your response. That's psychology, back from like Psych 101 days, Pavlov's, ring bell, salivate. Okay, get the conditioned response. Yep. Hey, when I'm in bed, I'm sleeping or having sex. That's it. I'm not watching TV. I'm not scrolling. And then seeing those markers or those cues, like it's bedtime. It's not sit around for another 10 hours trying to sleep. No, you sleep where you're supposed to sleep. I remember like when in PT school, I always would study in the exact same spot because that's where I was going to take my test, and just that condition response, and athletes do the same thing. Athletes, high level athletes, they practice the exact same way for that layup, so that when they get to that, that's not a distractor. It's just hit there, boom, done.
Exactly.
So the stuff that you're talking about, I mean, it's not rocket surgery. I mean, it's stuff that we've known for long times, and it's just like looking at it differently and just approaching it with this focus.
Yeah, it's really cognitive behavioral therapy, is what it really comes down to, is and that's really the gold standard for sleep dysfunction. There's not a single medication out there that is going to give someone a better sleep or a better quality of sleep. They all have their negative side effects. And so the gold standard really is cognitive behavioral therapy, specifically for insomnia.
Yeah.
So
I mean, we could spend we could have an entire another one talking about like the melatonin and all these other
exactly
sleep aids that people have been prescribed, and then we see rebounds, and we see all the negative effects of taking it for long periods and what that does to your own rhythms and biology. But that's not what we're going to talk about. So
that's right. That's right.
I just have one last question for you.
Yep.
Talk to me about, if I wanted to get more into, I wanted to dive into this integrating sleep science into my therapeutic alliance and therapeutic approaches with my patients. What is the best way to do that? Where should I start? Because there's a lot out there. I mean, we even already said, there's lots of stuff on fads, and, all the stuff about sleep hygiene gets all the, and I don't know if that juice is worth the squeeze. I think some of these others, those first three, are probably a little bit more. But where would you say, if I want to start, if people who are listening to this, where should they start to get into this, to feel comfortable so they can start approaching this with patients?
Yeah, so number one is check out those resources, the sleep health toolkit that KU provides, and start screening your clients. Because even if you don't feel comfortable quite yet intervening on it, just screening and having some conversations can be really helpful for your own kind of growth. So sleep health toolkit, and then next, check out there's a free app. It's called CBTI, for Cognitive Behavioral Therapy for Insomnia, CBTI Coach. It's a free app that's produced, I believe, by the VA. And it's a patient-centered app that's really great, has a lot of cool education in there. It has mindfulness, it has a sleep diary. There's so many cool tools within that little app that you could work with your patient. So once you've screened and you've identified, wow, there's an issue, and you're like, I'm not really sure how to approach this, that app will guide you through, some really helpful ways that your client can start to make some improvements. And then I love, to read books on certain topics or that I'm interested in. And so I highly recommend Why We Sleep by Matthew Walker. That's like the big popular book that everybody knows about. It's really, really fascinating. It's really evidence-based. And so that's sometimes a great place to start. And then I really think the biggest change book that's probably going to have more impact for you as a clinician and potentially for your client is called The Sleep Fix. And it's written by Diane Macedo. If you recognize her name, she was, I believe, an ABC News anchor. She really takes you on a journey of her own sleep struggles as a news anchor, having to work all these crazy hours and live in a smaller apartment in New York, and how she overcame her her struggles with sleep, but also provides just gold information on that improvement process and some tools out there. So can't say enough great things about that book in particular. So maybe those are some good resources. Of course, there's some Con Ed courses out there. APTA generally has some sleep health presentations at CSM, etc. So definitely, pay attention when you're registering for those conferences as well. Okay,
so we had the sleep toolkit with KU. Then you said the sleep app. Tell me that one again.
CBTI Coach. CBTI Coach.
Okay. Then the names of those two books again.
The names of the two books again are Why We Sleep by Matthew Walker and Sleep Fix by Diane Macedo.
Okay. And then what you forgot to say is your articles would also probably be, I think I remember reading them. It's been a while, but if I remember right, you had some information in there also that might help people. So I think that those would probably be some good maybe a good starting point also. I don't think you'd be opposed to people reading your articles and stuff.
No,
Yeah.
and you know the research is still a little at its infancy. There's a great article in PTJ that Katie published several years ago, and then we have an article right now, really a clinical commentary with example case that's in review with JOSPT right now as well. So that one should be out. So that's Mark Shepard, Katie Sansakong, and myself, and that one should be out hopefully in the next several months.
Awesome.
So.
Well, Brett, I am so happy that we were able to find time to talk about this and catch up a little bit on from our days back at Bellin. And it's a way super impressive to see not only the increased publication that you are doing anyways, but also on the sleep and really taking the lead and having some of those clinical commentaries and helping craft stuff with the APTA about, where we fit as physical therapists in this space and that it is within our scope. And we should be talking about health and wellness with all of our patients and figuring out, where sleep, is it a cofactor? Is it affecting? Is it being affected by, which came first? But, as we were talking about at the very beginning, I think, using it as a somewhat of a marker of their own health or recovery from the condition, if it's being affected, so like we are using with the PSFS in other ways, I think gives you some of those ways in the insomnia questionnaires, or just purely asking, how is sleep going? I loved your aspect. You ask him, is this condition affecting your sleep? Or is the sleep affecting your condition? And is this a new thing, or is this an exacerbation of a chronic problem? I think gives us just some basic tools that I have in my hands that I could go see somebody on Monday with, that will at least help me broach the topic a little bit more, even if I don't know all the what to do. But until you know that there is a problem, then you won't know that you should be doing stuff. And I think what I have heard from you is this is an undiagnosed problem that we're not asking our patients about this. And if we do, we're going to see that it's bigger than we thought. Because we've never been asking. So
100%. Well said.
Awesome. Thank you so very much for your time today. Thank you, everybody, for who's been here watching this next level interview with Dr. Brett Neilson, who's currently at HPU, but also has stuff out there in publications that you'll be able to find. He's made some great recommendations. I hope people really start diving into this and taking you up on your calls to really start addressing sleep with our patients. So thank you again.
Absolutely. Thanks for having me.
Thank you, everybody. You have a great rest of your day. Talk to you later. Bye-bye.